Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher, and today we are at episode 123. I appreciate all the listeners. Now, I'm recording from my laptop today, so I just wanted to warn you. So it may sound a little bit different. I am trying something new, and I'm working off-site. As you know, I always make sure we have an episode each week, so we're going to go ahead and hopefully this will work. So I hope everybody's having a good start to your last week in February. But you know what that means? That means this is Top 10 Tuesday. So what I'm going to come up with today is the top 10 ICD-10-CM coding errors and how to fix them. So sometimes you get the errors, but then you don't get how to make them accurate. So first of all, the top 10 primary diagnoses in ICD-10 are orthopedic aftercare, which starts the Z47 code series, heart failure I50, encounter for other post-op aftercare Z48, type 2 diabetes E11, chronic obstructive pulmonary disease J44, I10, which is essential primary hypertension, pressure ulcer L89, other disorders of muscles M62, sequela of cerebrovascular disease I69, and then abnormalities of gait and mobility is R26. So what I wanted to talk about would be the issues we've had with ICD-10 and definitely some mistakes since the implementation. First, I did want to apologize. I'm sure you heard my phone go off earlier at a notification. That happens a lot. I forget to turn it down. I apologize. So hopefully that won't disrupt anybody. So some of the issues since ICD-10 implementation. One is utilizing acute injury 7th character A codes. Diagnoses not supported by medical record documentation. One that's a real big one, number 3, is something called POC or point of care. Clinical point of care is the point in time when clinicians deliver healthcare products or services to patients at the time of care. The reason this is so important is because some patients can present with things like sepsis or ulcers or illnesses where these conditions started by picking them up in the hospital instead of coming in with them on admission. So it's really important to know the point of care situation when documentation is key, especially in a hospital setting. Number 4, non-specific codes when the medical record supported a higher specificity. I see that all the time. To me, that's just part of coding laziness. You have to be specific and really try to find that specificity within the record. Number 5, etiology manifestation conditions coded as separate and non-related conditions. Number 6, sequencing of diagnoses does not support the service intensity or focus of care. And this is going to be important, especially as we move into some of the new 2021 codes for E&M because of how we're going to be documenting those. Number 7, supportive diagnosis or condition codes that were not included for therapies. Number 8, failure to include tobacco use or history when required for cardiopulmonary diagnoses. It's actually mandated within the ICD-10 book. Number 9 is the use of Z codes for complicated wounds. That's not a good idea. And number 10, failure to include conditions with potential to affect the patient's response to treatment. And so those are things that have been issues, have been problems, and can lead to coding errors. So let's take a look at that one by one and see how we can fix it. So 7th digit character use. So since ICD-10 came out, most of you and most of us were taught that home health would never use the 7th character A. We learned that A would only be used with the initial episode of acute care settings, hospital, ER, doctor's offices, and D was reserved for subsequent episodes of care, home health. Initial grouper didn't even accept A in home health focus. And then the focus on the word active rather than initial is a big deal. Clarification. So here's the fix on that. The coding clinic has since clarified the use of the 7th character digit. So 7th character A, while used for initial encounter, should be used when a patient is actively receiving treatment for a condition. You're going to see it quite a bit in fracture care for sure. And when you use this for when a patient is actively getting care for conditions such as wounds or IV therapy, the grouper has been updated to accept A in certain conditions. And that's when I'm talking about outpatient facility as well. And then when we talk about when active treatment begins, that's a big one. But active treatment can begin in the inpatient or office or physician office setting and continue when the patient is discharged to home and still be considered initial encounter, even if the patient has been seen by multiple providers. Never use seventh character A for injuries. Use characters denoting subsequent or sequela. Once a patient has received treatment for an injury by a physician, emergency department, or inpatient facility, home health provides routine care for the healing or recovery process or phase. In the routine or recovery phase, the seventh character is now D. The most common home health examples require subsequent encounter seventh digit characters are healing traumatic or pathological fractures. See, I told you any fractures were going to come up at some point. There are 12 different seventh character for subsequent encounter to choose from, depending on the healing status or type of complication. The most used in home health, and the reason I'm focusing on that is because that's where the coding errors come from, would be A for active treatment, D for routine aftercare, and S for sequela. And then for complication codes, active treatment refers to treatment for the condition described by the code, even though it may be related to an earlier precipitating problem. So understanding those concepts is pretty big. So some examples of using these seventh digit characters. So a patient is fractured or with a fracture of a right distal ulna, has severe swelling, casting delayed until edema subsides. That would be your S52.601A. And we have laterality, we've got what part of the arm you're dealing with there. So there's a lot of information on that area. And then patient with fractured right distal ulna from a fall, arm is in a cast, S52.601D. Patient with healed fracture of distal right ulna a year ago, bone is not aligned correctly, causing chronic pain. That's when you get into your sequela. So that's your S52.601S. Let's say you have a patient with an infection of a cholecystectomy incision referred to home health for wound care and IV antibiotics. Well, now you're in the injury section, which is the T code section. T81.4, you have two placeholders, XXA. And then patient with disruption of abdominal incision, not infected and has been left to heal by secondary intention, T81.31XD. So make sure that you really look at that from that standing as far as focusing on that seventh character add-on, because I should say digit add-on, because it can really affect your reimbursement and what is submitted to the payer from a facility and also from a physician perspective. Okay, so the next one we want to look at when we get into this would be supported diagnoses. Now, when I talked about the point of contact, the POC must match the OASIS and the final bill for the first 6 diagnoses. All diagnoses must be supported by the provider's documentation, but that's a given. If there is documentation of a manifestation, but the etiology has not been documented by the physician, you have to get verification or query the physician. So for an example, stasis ulcer with no etiology, that's a problem. Coding for medication list or patient statement. Keep in mind that many medications are used off formulary, so a diagnosis has to be verified. And do not code possible, borderline, suspected, rule out, or anything like that. Code your symptoms until a definitive diagnosis is made. That is diagnosis coding 101 when you're really trying to make sure that you're accurate. And then when you're dealing with coding resolved conditions. So resolved conditions should be coded as history of, if still relevant to the current point of contact. So patient with current lung neoplasm had mastectomy for breast cancer 2 years ago. Patient with primary diagnosis of hypertension had a TIA 6 months ago. Or patient with a Foley catheter has a history of frequent UTIs. So do not code resolved conditions that have no impact on the current point of contact. Resolved breast cancer 2 years ago for a patient with a TKA, UTI a year ago for a patient admitted for a fractured arm. So those are things that you have to know if they've resolved or not. Unspecified codes, those get a little tricky. I was actually surprised when I-10 came out that we were going to have a lot of unspecified codes still. I thought the point was to clear up the specificity so we didn't have some issues there. Because all patients are not the same, we are going to have issues sometimes of an unspecified or other specified situation. And those are used for when the information in the medical records provides detail for which there's just no listed code. So codes that are titled unspecified are for use when the information in the medical record really isn't sufficient enough to assign a more specified code. Some unspecified codes may also affect your HCC score, so be careful with that. There's some default codes as well. So I-69.3 is the default code for CVA or cerebral vascular accident or stroke, but I-69.3 codes with a sixth character of 9, and that doesn't mix very well. And it doesn't give you a specificity to affect the side, but you still have to document it. And then it's inappropriate to select a specific code that's not supported by the medical record documentation. And so you can't conduct medical unnecessary diagnostic testing in order to determine a more specific code. You have to make sure that you have something there where it's medically indicated to order a test. So some unspecified examples, and it's hard to get away from these. Anemia, D64.9, abdominal pain, R10.9, angina, 120 or I-20.9, COPD, J44.9, Alzheimer's falls into that, G30.9. So when you're dealing with some of these unspecified codes, really try to see if you can get more specified, but I know sometimes it's very tough to do that. I know some other and unspecified codes for documentation of diabetes. There's an E11.69, which is diabetes with other specified complications. But if the patient also has, let's say, diabetic osteomyelitis, then you have to also pick up the code osteomyelitis in the M86 code series. So using just the E8 or E11.8 diabetes with unspecified complications is incorrect, because if a complication is the result of diabetes or any other condition, there has to be documentation of the complication as stated in the record. So really have some understanding of how that works when you are capturing and sequencing those codes. Okay, codes to support therapy. So this always comes up when I'm dealing with a lot of physical therapy practices and things like that. And it's funny because there really aren't anything that you could call a true physical therapy diagnosis. There are many diagnoses that support the need for therapy, and ultimately the therapist evaluation and documentation will support the need for the therapy. But conditions that are integral to the disease process or injuries being addressed by the therapy, they're not necessarily coded separately. If episode is therapy only, code the condition or problem that's causing the condition that therapy will be addressing. So, for example, severe weakness due to exacerbation of COPD, abnormalities of gait. So that could be, in the R26 section. Repeated falls or falling or a tendency to fall, R29 code section. History of falls. Now you're in the Z code section, and this can be used in conjunction with each other. You're in the Z91.81 area, but just make sure that you're aware that it's about the therapy, not necessarily about other conditions in the relationship there. Now, the use of tobacco codes. So some cardiac and most respiratory conditions in ICD-10 require the addition of tobacco use when applicable, and it's required. So that means that it is mandatory. So for example, exposure to environmental tobacco smoke, Z77.22, exposure to tobacco smoke during the prenatal period, P68.81, history of tobacco use, Z87.89, occupational exposure to environmental smoke, Z57.31, and then tobacco dependence must be specified by the provider, and that's in the F code section, and then tobacco use, Z72.0. So make sure that your physicians are aware that, especially cardiology, pulmonary, anybody who's dealing with upper respiratory situations or the heart, that these are mandatory codes. Now, Z codes, when we're talking about circumstances other than disease, injury, or external causes, but they are listed as problems, and aftercare Z codes, these are important. So, Z codes, history, aftercare status, encounters, and some can only be primary and some can only be secondary. So, look at the code and make sure, just to make sure you're fixing it, that it is either primary or secondary, and then there'll be a reference next to the code in the tabular list of your ICD-10 manual that'll say PX or SX, determining whether it can be used as primary or secondary. And never used for complications of infected or dehisced wounds. You need to go to the T81 code section to make sure that's descripted appropriately. Aftercare Z codes. So never use aftercare of injuries or fractures. Use instead the original injury code with the appropriate 7th character from Chapter 19, generally listed as the primary to indicate the reason for the encounter, but can be used as a secondary code to indicate that aftercare is being provided, as well as the primary reason for the admission. So an example, patient admitted to the hospital following an MI or possibly even home health, also had a pacemaker inserted. So you have your acute MI, somewhere in the I-21 range, and then aftercare following surgery to the circulatory system could be a Z48.812 area. So knowing how to sequence those as well. Comorbidities. Okay, so what these are, comorbidities are the simultaneous presence of two chronic diseases or conditions in a patient. They may be long-standing, they could have occurred at the time of or at any time after the primary condition. Usually coded as a secondary diagnosis if it affects the point of contact, even if it's not the focus of the current episode of care. But the big thing about comorbidities is that has to be documented by the provider. So it's not something that ancillary staff can document. So make sure that you take those coding errors to heart and how to fix them, just so you're understanding the process. I think ICD-10 sometimes gets overlooked since we've had it now for almost 5 years, and not always looking at the fixes, just looking at the errors. And so a lot of times it also has to do to link. So because we were dealing with coding, I also want to talk to you about a possibility, and this is my middle commercial message here. I have a new, you've heard me talk about my Coding Corner membership and what I have on my website. Well, I have 2 options now for Coding Corner. So if you're interested in signing up for that, we have not only the regular membership, which is $1,200 a year for specialty coding questions, billing and coding troubleshooting, billing and collection questions, revenue cycle management and appeal assistance. We give you Medicare positions on coding, and you can have up to 2 specialties and 5 staff members per contract, and we get back to you within 24 hours. But now, as of this month, we have something called the Coding Corner Executive Membership, and this will be $1,800 a year, and it also includes everything I just mentioned, plus free quarterly webinars on various coding topics and quarterly newsletter. And then I'm going to start doing a once a month Ask Me Anything session where we'll be online, and I'll be either on a Facebook or live video or on Instagram story or somewhere where you can actually access me and ask a question. So let us know if you are interested in that, and you can go to the website at terryfletcher.net, and hopefully that will be something that you'll join. So I've had a lot of people ask me questions lately, and I just want you to know I appreciate the contact. I love hearing from everybody, but I'm a consultant and this is a business and this is what we do. And so I get over 100 coding questions a week. And sometimes in one day, I have had 100 questions, believe it or not. And so about 26, 27 years ago, we started charging for our time, and kind of that's how my whole corporation started. So that is what we do, and we're here to help you. But always remember with coding questions, it takes us time to research, to make sure it's accurate, know your specialty, and making sure that when we email you back that you have ammunition to use for against that insurance company, or to discuss something with your physician, or to clarify your position, or even just to give you peace of mind that you're doing things correctly and accurately. And so that's what you're paying for. You're paying for expertise that pretty much does the research for you. So for those of you that have contacted me for questions and things, I try to give you at least one question, which just to, so you know what you're getting. Obviously, you feel comfortable. You're listening to the Codecast and some of the different offerings we have. But I just wanted you to know that once we do answer a question, we do then charge for services. So just be aware of that, just like you do in your practices. So what I wanted to talk about today on it's kind of a personal thing, but it's really when we talk about wellness, you've heard all about physician burnout and staff burnout, and just keeping I've talked before about keeping a healthy mind and everything, but some people don't always talk about financial wellness, and I think that causes a lot of stress and worry for people. So, because as a consultant and a reimbursement and coding and auditor and the consulting I do always seems to stream back to money, I wanted to give you some tips on how to improve your financial wellness. So, just some insights there on maybe something that can help you out. So number one, set up monthly money dates. So one of the smartest things that you can do for your bottom line is just review your finances. Dedicate time each week or month to tackling your money management. These intentional money dates with yourself or your family or partner could help you save money throughout the year. So during your money date, review where you are in terms of your budget process. What debt are you trying to reduce and your savings plan? Have unexpected expenses? Focus on how you can handle those and better prepare yourself for the future. Number two would be practice unsubscribe Sundays. So spend an hour or a few minutes every week, unsubscribe from the many promotional emails that clutter up your inbox, because these might tempt you to shop impulsively when you do not want to spend that money. And just so you know, folks, I am preaching to the choir here, because those pop-up ads drive me crazy. And I love buying things for my daughter. And so, and sometimes for myself. And so sometimes it's just really helpful. And I do not keep credit card balances. I hate them. And so, and I always want to have my credit score over 840. So this is where I'm coming from with this, where I'm constantly checking that. I'm a big budget person. Some of you know my degree is in economics. So if I didn't do this, I'd be doing something in finance. Number three is get a money buddy. I know that sounds weird, but it can be helpful and encouraging to share your goals for the future and compare notes with someone who cares about you. And you may have experienced some of the same struggles along the way, and you can just keep each other in check. So did you need to spend that $3 this week, or did you need to spend that 20 last week? Could you have found something in the house to make for dinner versus, ordering that quick Postmates or, delivery service? There are ways to really, help you get your budget where you need it to be. And the last one, keep your goals positive, not punishing yourself. In an effort to achieve your financial wellness goals, focus on the positive rather than the negative. As opposed to saying you want to cut spending, think instead of what you want to put that saved money towards and attach a specific number to it. So this process can help you keep track of progress and ultimately reward you for getting there. So remember that the path to financial wellness, and I think that's a lot of your mental health as well, is very personal and in no way linear. So you do not have to rely on specific time of year, such as the new year, to make money resolutions you can stick to. When you're ready to make the commitment to your financial wellness, not just do it for your bottom line, but for your overall well-being and peace of mind, you'll have a lot more, a lot better chance and greater success of achieving your goal. But, we all are getting ready to do some spring cleaning. I know I've already started, and getting some things for my house done and changing some things out. This is a time maybe to really think about your financial wellness. We're in 2020. We are in an election year, so you don't know what's going to happen in the market. And, just this is a point where really to take a look at that. So hopefully those tips helped you. Hopefully you were happy with our Top 10 Tuesday. And I will next time see you in March. So everyone, make it a great day. Make it a great week. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.